So welcome everyone. You are with us here at the Diagnosis of Incarceration speaker series for fall 2024 of the Program in Criminal Justice Policy and Management at Harvard's Kennedy School. My name is Katie Naples Mitchell. I'm the program director. We are joined today by three phenomenal panelist experts and by our guest moderator for the entire series, Kara Buchanan, who herself is an emergency room physician and also a student here at the Kennedy School who has taken on this phenomenal project to coordinate the series this fall. I'm going to give just a very brief set of reminders about the kind of community we're trying to foster here, and also just some kind of suggestions for how we can engage with each other. So to start, this is being recorded. So please keep that in mind with any questions you choose to ask or not in terms of how much you choose to disclose. It will be posted ultimately on our YouTube channel and on our website. We've dropped the link, but for anyone who is joining since we've done that, I'll just drop it one more time because I know you won't access the archived link. So that is our website for the series, where again, we will post the recordings of the videos. And again, they will be on our YouTube channel as well. It takes us a little while just to edit things and clean things up, but they will be up within a few weeks usually, or certainly by the end of the semester. A couple other things about questions and engagement during the conversation. We want to reserve time for the panel to be able to kind of give us the overview and the discussion, but we do encourage questions to be asked as they arise in terms of keeping them in a queue in the chat. So if you're able to write your question in the chat, then when we do break for questions at the end of the discussion, we'll go in the order in which those questions appear. But of course, you can also choose to raise your hand at that point. And if you have resources to share or related reports or scholarship you want to include, we encourage active engagement in the chat throughout the conversation. I think that's all I have to say at this point. So I will pass to Kara, who is again our phenomenal guest moderator, to kick things off. Go ahead, Kara. Thank you.
Yeah, thank you so much, Katie. Yeah, very pleased to be here. And I know we started this series last week, but just in case for folks that weren't able to join us then, I'll just kind of go through a brief framing and overview of the series to get started. So huge thank you to the team here at the Kennedy School and the Program in Criminal Justice Policy and Management, our faculty director, Sandra Susan Smith, our program director, Katie Naples Mitchell, and our program administrator, Brian Welch. This is my email. I'll be your series moderator. So please feel free. We love hearing from you. Please feel free to reach out, touch base on any topics or clarifications, and you'll be able to revisit the website, as Katie mentioned, kind of for updates on recordings and available resources. So this week was a really big week. I think it's really important just to kind of get started and take a moment to think about what happened yesterday, 6:10 p.m. in Missouri, where pentobarbital was used as a lethal injection dose in the state execution protocol of Marcellus Williams. And I bring this up not because we're going to really talk too much about capital punishment today or any details related to the case, but just to really center this community who I know may have been very personally affected, as well as the communities and networks that we are in touch with doing this type of work, that this happened, and is a reminder of the intricate connections between medicine and policy, medicine and law, medicine and the criminal legal system. And I'm really pleased that we'll be able to kind of bring together this community today to foster dialogue and conversation, particularly in a week like this one. I also wanted to just touch base about kind of what we seek to do in this dialogue is really bring a very thoughtful and intentional group of folks together, many of whom and most of whom have had direct contact working with justice-involved patients, many of whom may themselves have been justice involved. And that will continue to be a very mindful effort that we make throughout the series. A lot of identities may be invisible or visible, but I just wanted to kind of thank this community again for coming together and fostering this dialogue, and know that we're really thinking a lot about representation throughout and who's able to be here and not able to be here and that presence. So really encourage the chat, really encourage feedback, and looking forward to hearing from you all. So just to kind of take you back for a moment, earlier this summer at the Harvard Radcliffe Institute, we gathered leaders from across the country to really center ourselves around this big question. What are the 5 biggest problems we can think of that we need to solve to address inequity in healthcare provided to justice-involved patients? Our group came up with a, kind of proposal that these were some of the 5 components. Last week, we spoke a little bit about narrative and issue framing, who's there and who's not there to both narrate and help frame issues. Who do we need to be mindful about including? This week, we'll speak a little bit about defining standards of care. And throughout the rest of the series, we'll be thinking about privatization and funding, financing, transparency, oversight, and accountability, and inclusion of quality data metrics, and of course, challenges to efforts in alternatives to incarceration. We'll be coming back to these kind of 5 ideas and really using this community as a space to think about any changes or thoughts or amendments to these 5 kind of main problems that we've identified. Today, of course, I will be joined by 3 experts to help hone in on defining standards of care. And I just wanted to introduce each of them. So we have Dr. Will Weber. Dr. Will Weber is an assistant professor of emergency medicine at Rush University Medical Center and the medical director of the Medical Justice Alliance. His fellowship work was focused around the rights of those in carceral settings, and he's consulted with the World Health Organization and serves on the public health and medical legal committees of the American College of Emergency Physicians. He is just coming after a shift, and so we're so happy to have his expertise and experience with us today. Dr. David Himmelstein is a distinguished professor of public health at the City University of New York's Hunter College. Previously spent some time here in Cambridge as associate professor of medicine and chief of the Division of Social and Community Medicine at the Cambridge Health Alliance. Dr. Himmelstein has authored or co-authored more than 150 journal articles, many of which featured in JAMA and the New England Journal of Medicine, as well as 3 books, which have highlighted the high administrative costs of the U.S. healthcare system, including a 1984 study of patient dumping that led to the enactment of the Emergency Medical Treatment and Labor Act, an act that is the reason I chose to become an ER physician. He co-founded Physicians for a National Health Program and received his medical degree from Columbia University. He completed internal medicine residency at Highland Hospital, University of California, San Francisco, and a fellowship in general internal medicine here at Harvard. And then Dr. Eric Eiting is an emergency physician and recently served as a professor and vice chair of operations for emergency medicine at Mount Sinai in New York City. Previously, Dr. Eiting worked as director of, advance the slide there. Previously, Dr. Eiting worked as Director of Population Health for Correctional Health Services at New York City Health and Hospitals. Particularly, his use of telemedicine and incorporating that into the system has helped to expand access to specialty care throughout the system and cut costs, improving care coordination along the way. I am particularly proud also to share that Dr. Eiting served as the medical director for inmate health services at the Los Angeles General Medical Center, which was formerly LAC USC Medical Center, where I also had the privilege of completing my residency training and staffing the jail emergency room there, which has deeply affected my work and inspired me being here today. Dr. Eiting also served as medical director for USC's Correctional Health Services. While there, he also profoundly worked to continue to expand the telemedicine and telehealth service. So Will, David, and Eric, very illustrious backgrounds. Thank you so much for being here and welcome. I'd like to just kind of get started and kind of turn back to this topic of defining standards of care. And as you can recall from last week, Emily Widra of the Prison Policy Institute helped us kind of frame this picture, but I want it from a physical and visual standpoint with a lot of data. This week, I kind of wanted to get started with framing the issue of standards of care with a little bit of the legal framework that kind of grounds us in this conversation, which is the U.S. Supreme Court Estelle versus Gamble 1976 ruling regarding deliberate indifference. And the statement here is deliberate indifference by prison personnel to a prisoner's serious illness or injury constitutes cruel and unusual punishment contravening the Eighth Amendment. So with this kind of grounding framework, we sort of have started to define standards of care in the clinical space. But of course, as Emily reminded us last week, this is a system that is connected thousands of different facilities and millions of people, each of these institutions with their own take on standards of care and how they address this Estelle v. Gamble, court ruling that they need to not deliberately be indifferent to the serious medical needs of a patient. So just to get started, Eric, you have worked across the country, spanning from Los Angeles to New York City, and your work has involved leadership in securing access to quality care for justice of all persons. And reviewing those standards and navigating those systems, I wanted to get started by asking you, to what degree do standards of care really exist across US jails, prisons, and detention centers?
Thanks for the question. And I just, thanks for the introduction. And I really want to say how grateful I am that you said Marcellus Williams' name, that you brought that up. I'll tell you that I was in the middle of working a clinical shift when the message came through that he was executed. It's like a gut punch, and I think it's really important that we shine a light on that. So thank you for taking a moment to bring that up. I'll tell you that the standards of care definitely exist, but I'm not sure that we all are in agreement or alignment in terms of what those standards are. And it does feel like there's always this sort of contextualization, I mean, I think, in order to deliver care in a correctional setting and to be able to do it well, it means on a daily basis that we're trying to overcome some of the structural barriers, and that we look at, when we look at things from the lens of a healthcare provider, the things that are important to us and the things that we value are not necessarily the primary goals of some of our correctional staff, right? I mean, like, I like to frame this as our main charge is health and wellness of people and patients, whereas on the correctional side, their primary charge really is safety and security of settings and of communities, and just acknowledging that those things can be at odds with one another. We definitely have, whether it's from an academic standpoint or from an organizational standpoint, we have some leaders in this space. I'm thinking of the National Commission on Correctional Healthcare, definitely is probably the most prominent organization that we sort of look to when we're trying to identify those standards of care. But I think that where we really just need to be careful is we can't fall into that trap of saying, it's just too hard in my setting, or my setting is somehow different. And I don't want to take away the fact that every setting, a jail is going to be completely different from a prison. When we're talking about a smaller community correctional center, and how that differs from the LA County jail system, which is the largest system in the country, probably in the world, if I am getting that number correctly. So like there are going to be nuances that have to be overcome, but we can't let some of those individualized differences be a reason why we can't achieve and accomplish what we are deciding are the standards of care.
Yeah, absolutely. And I just want to make some space. Will or David, did you have any notes on the standards?
I actually have a different perspective. In my view, there really are no standards of care. I mean, Medicare, Medicaid promulgate standards that are enforceable across the nation. And the licensing agencies have standards. Those don't apply to prison healthcare. There are voluntary standards promulgated by organizations such as those that Eric was talking about, but they won't even tell us which jails and prisons have agreed to abide by those standards or have even been inspected. Only 17 states have any standards that are formally in place. And the standard the Supreme Court put on deliberate indifference, I mean, how pitifully weak that is indicated by the fact that in that case, they actually ruled against the inmate. He had a 600-pound bale of cotton fall on him, and refused to work because he was so injured and was put in solitary confinement. And the court found for the Texas Department of Corrections on the grounds that it wasn't deliberately indifferent. So, I mean, I think the profession likes to imagine, and there are certainly some prisons and jails that adhere to standards, but in terms of anything enforceable, anything that's actually folks in prisons can rely on, there's, in my view, nothing reliable across this country for the vast majority of people who are incarcerated.
Yeah, and I can jump in. I agree with David. I think the standard, the Eighth Amendment standard is so low. I think there are, as Eric had mentioned, there are other kind of volunteer organizations, and then sometimes there are like the ICE puts out national detention standards. Now, again, these are generally far below what would be considered community standard of care, and I think underscores the need for standards. But I think right now, as a country, we are just falling so far short of what would typically be provided as healthcare.
Yeah, absolutely. And I'm just stopping the share real quick because I do want to kind of just take a moment to go over a few, just to review what was mentioned regarding the NCCHC standards and the ones that do exist. So I'm just going to reshare my screen here to kind of pull that up and kind of go over what is there and where does it fall short. So I guess on a federal level, we can kind of, there were Federal Bureau of Prison Standards for federal facilities. So there was, pursuant to the Correctional Officers Health and Safety Act in 1998, the Attorney General and Secretary of HHS provide some guidelines, mostly around infectious disease prevention, detention, and treatment of inmates and correctional employees who face exposure to infectious diseases in correctional facilities. This is kind of the text from their mandate. How that looks is, of course, imperfect, but they built a website. There's some resources available. I do encourage, if anyone wants to check this out, kind of clicking through and just seeing there are some, standardized protocols related to alcohol withdrawal, things that are very important to kind of make sure that a person that's coming on, maybe with different training in any of the different medical specialties, is very consistently able to resource and look at something on shift or while they're providing care. There's a kind of like federally approved resource. You'll see that they get updated sporadically. And, particularly in the realm of hepatitis and things that have, been able to kind of be updated with curative, regimens. This is important resource to continue to kind of monitor and see how the federal government is keeping in touch. On the other side, as Eric mentioned, there's kind of this National Commission on Correctional Healthcare, NCCHC. And this is a private for-profit organization, and it makes a costly recommendation if you kind of buy into the contract for policies and protocols for non-Federal Bureau of Prison facilities. So it is sort of one of the biggest organizations out there. Its enforcement tool is basically loss of the award of accreditation. But, various lawsuits across the country, and I think we'll talk a little bit more about kind of the work of Medical Justice Alliance. There is, not a real mechanism beyond kind of losing the accreditation award and then kind of whatever subsequent legal proceedings go from there, as well as the fact that the facility accreditation status is not made publicly available. I'll kind of just show you a brief screenshot of their website on that. Regarding conflicts of interest, the NCCHC is sponsored by private prison healthcare contractors. So there is not a clear delineation between kind of this as a private entity and any kind of like financial interactions with prison contractors. So this just briefly to kind of highlight some of the complexity of, well, we have an accrediting body here for non-Federal Bureau of Prison facilities, but, by policy, the NCCHC doesn't release the list of facilities that actually have gone through the accreditation process, which adds, as we spoke about last week, a layer of transparency, a layer of invisibility about like really what facilities might be even having gone through this accreditation. And then when, on the website, they're like, where can you identify maybe healthcare companies that have gone through accreditation? The NCCHC is very clear. It doesn't accredit a specific type of company, state, or agency. It doesn't really go through electronic health record vendors, et cetera. It's really awarded to the correctional facility for compliance with the NCCHC's standards for health services. And if you're wondering what those standards are, you can actually, interestingly, you cannot download them on a PDF. So they're not available like the Federal Bureau of Prison resources are available. And I actually worked with an organization to raise some funds for grant funding so we could go through, buy these books, which are, amassed to a couple $100s, and have the physical resources, present in facilities to really reference. But that is just a little bit of context. There's a whole lot, of course, with the NCCHC context, but this is just to kind of briefly introduce you to kind of what those are as we continue speaking. So I'll bring up kind of the next question, which I want to discuss with Will. So Will, we'll talk a little bit about kind of your efforts with the Medical Justice Alliance. And in your capacity there, you've really had the opportunity to kind of review patient cases, go through and review medical records, kind of work with the persons affected by some concerns regarding their medical care. And I'm just wondering if you could speak a little bit about lived experience and how the accounts that you kind of get with persons within the Medical Justice Alliance map onto are there standards, kind of that are being followed in these facilities? And where have there been some of the more striking moments that are revealing of, lived experience not quite matching up with standards of care potentially in jails, prisons, and detention centers across the country?
Yeah, so just briefly, the Medical Justice Alliance is a group of volunteer physicians across the country, nonpartisan. It's a nonprofit group. And what we really do is review medical care for patients who are behind bars and just see how does it line up. Because we're talking about kind of standards within the medical legal system. And across the country, most other places, you have what's called a community standard of care. And so we have many, many guidelines by the American Diabetic Association, American Heart Association for managing things like high blood pressure or diabetes, when should you get your colonoscopies and other screenings. And so what we will do is review medical records and just point out if there are big gaps in care compared to what they are receiving while incarcerated, compared to what the national guidelines would say. So I think we unfortunately have seen, and there are a lot of different reasons for it. Many providers in the healthcare field in these correctional facilities just are really stretched thin. Sometimes they don't have access to the most current evidence and things like that. But for instance, we had a woman a couple of years ago. She was developing chest pain and shortness of breath while in a detention facility. So she was having chest pain and shortness of breath. Now, the American College of Cardiology, the American Heart Association have guidelines. So generally, you check an EKG or your heart rhythm to make sure you're not having things like a heart attack or inflammation of the heart muscle. You'd also do things like a chest X-ray to make sure your lung hasn't collapsed or you don't have a pneumonia. This lady was, again, she was feeling racing heartbeat or palpitations, chest pain, and shortness of breath. And she was documented as having a heart rate of 160 beats per minute, which is extremely fast. That would be something where if they were in the ER, they would be rushed to a room immediately, probably end up in the ICU. And, while she was in this facility, there was a mid-level provider who saw this patient and pretty much said, well, you're just anxious, you're dehydrated, and go back to your room and just drink more fluids. Didn't do an EKG, didn't do a chest X-ray and things like that. So when we're able to have a physician to review those medical records, we can share with the judge or the parole board or whomever else just a little bit more about the medical context of what would be appropriate or not. And that helps them make more informed decisions. So unfortunately, we see a very large gap in care many times. Not all the time. There are some facilities that are providing good medical care, but many times we're seeing big gaps in care. And when we can explain the difference between community versus what's happening in the correctional facility, that helps judges get people better care.
Yeah, absolutely. And I think, just coming back to this idea of, how do we, as physicians and for those in the audience that have connections to, justice of all patients, whether they're under their care clinically or not, like how to represent that difference between the lived experience that kind of is really happening and what is kind of like set on paper as well. There are standards, these standards are being followed. And I wanted to speak to David a little bit about your work. So David, of course, you have, spent a lot of your efforts in kind of trying to really bring light to these distinctive elements that really occur in spaces of incarceration that are distinguishable from standards of care in general healthcare spaces. And I just wanted to kind of pose this question as kind of moving forward to how does standards of care in US jails, prisons, and detention centers compare with those in the general healthcare setting? And what are those features that you found most striking in kind of doing the work that you've done to expose what's happening?
Yeah. Well, in some ways, the lived experience of people experiencing incarceration mirror those of folks from similar communities outside of prison. They're most often from oppressed communities of color who have extraordinarily poor access to care outside of prisons and jails. And once they're in prisons and jails, their access to care worsens, which is almost unimaginable considering how bad things are in many communities. I mean, we did some recent research looking at copays and deductibles that are inflicted on incarcerated people. So, people making 5 cents an hour are told in order to see a doctor, you have to pay a copay. And in many cases, for half the prisoners in the United States, roughly, that copay is more than 1 week's prison salary. So if they were working essentially a full-time prison job, it'd take 1 week of their salary to make the copay. Now, folks outside of prison from many of the communities where these people are coming from also face unbearable copays and access to care problems. But these are, we think, substantially worse, and we found that the access problems were in fact horrendous for those folks in prisons and jails. And what that means is that chronic conditions aren't being treated. It's not just because of copays as well. We know that despite the fact that there certainly are some dedicated and fine doctors, nurse practitioners, others working in prisons and jails, there are a lot of really bottom of the barrel medical practitioners working in prisons and jails around the country, folks without residency training, people who can't get jobs elsewhere, who have horrendous records of malpractice and get hired on at prisons as the doctors. And we know that the rates of treatment for people with chronic illnesses like diabetes, hypertension, particularly maybe psychiatric conditions, that those rates of treatment are poor and the standards of treatment are poor. So the lived experience, I think, is in most cases incredibly bad. One of my colleagues in my research group at Harvard had a patient recently in Boston who had a severe congenital heart failure, inherited heart failure, had an implanted defibrillator. Well, that's high-tech medicine, that's great. The defibrillator was firing repeatedly when it shouldn't have, and that's a horrendous experience for anyone to go through. He experienced more than 20 shocks, and the folks who should have been responding to his request to take him immediately for care just didn't. When he finally got to care, he had been so disturbed by this shock, and basically, if you ever put your finger in a socket by mistake, we're talking about that tenfold worse or more, and coming from inside your body. And that experience so disturbed him that he asked to have his defibrillator removed. Didn't just ask, demanded, and died within the year. No clear cause, but almost certainly related to that experience and the deliberate indifference, which no one actually paid any penalty for. So I think it's clear that the actual standards of what's happening in many prisons and jails around the country are abominably poor.
Yeah, thank you. And I was really struck by this finding in the article that you were referencing. We've kind of put on the screen, and 53.8% of pregnant people in prisons that have copays, again, not all prisons do, but in the prisons that have copays, had a copayment greater than 1 week of prison wages. And of course, as we know, financial barriers exist across the general population and our justice involved patient population. However, of course, access to and communication and coordination of those resources is, fundamentally different, of course, in spaces of confinement. So I really appreciate that. I was wondering, Dr. Himmelstein, based on some of your work with the Physicians for a National Health Plan, you've worked on kind of campaigns that have thought about publicly controlled single payer systems. How do you think that structure would work in management of jail and prison care across the United States, since that is obviously very different than the fractured system that we have currently?
Well, first thing is that if we actually said that the financing provisions that are there for the non-incarcerated population also apply to the incarcerated population, then the standards of care that, for instance, Medicare and Medicaid promulgate would apply to the incarcerated population as well. So the prisons and jails wouldn't be able to evade those. And second is that it would bring, we think, substantial additional resources to bear for incarceration care, because the financing would come from the federal government, not depend on the states or cities, many of which are cash strapped. And financing for care would be equivalent to that for the non-incarcerated population. So it wouldn't solve all the problems by any means, but it would, we think, be helpful.
Absolutely. And Eric, I was wondering also in the kind of work that you've done, and I'm just going to stop the share real quick because we'll kind of focus on the faces instead of the slides. But in the work that you've seen kind of in LA and in New York, were there efforts on a local level to sort of, bring forth, commission to standardize care, or what kind of like oversight mechanisms have you interacted with throughout your work?
Yeah, I mean, I spent some time working at Rikers Island, and I think it's not a secret that there's been federal oversight in that facility for some time. And I think it's important to parse this out, right? I mean, like the original question is like, do standards of care exist? And the reason why I feel very strong, like the standards of care are universal, right? They're standards, right? Like this is something that we accept as the medical community. And that's really the genesis of this. Now, when we talked about lived experience, like the question then becomes like, are we living up to the standards? And I think that we're all in agreement that it like that there is a collective no, and some people are doing better, right? But I think that it is not hard for us to find instances where people are not meeting the standard of care. But I think it's really important to say that out loud, because like we can't allow for this exceptionalism. Like that's why, people are able to get away. Like we have to say like the standards are the standards, and they are agnostic to the site of service where we're providing care. And one of those places where we're going to be providing care is going to be jails and prisons, and other correctional settings. And we need to maintain that same community standard of care. But there's, I would say that there's variable levels of oversight. I also appreciate the point that was brought up about the copay for pregnant persons. When I used to oversee the high-risk obstetrics clinic in the LA County Jail, what was interesting is like, just as we were sort of teeing this up and getting it started, we had several pregnant patients who would come to us because essentially they were being denied access to termination. And what was happening was two things. One is that it took us some time to be able to establish a timeline, or like really just determine how far along patients were in their pregnancy. And as we all know, the further along you are, that changes the way that we would approach things like a voluntary termination. But they were coming in with these talking points and essentially saying, like, this is a violation of my civil rights. And what they were telling us was, if I were not incarcerated right now. If I were out in the community, I would be eligible for Medicaid. I could enroll tomorrow and I could have a termination the following day. And all of those things were true. And I think that it's really important to make sure that we are arming our patients with similar talking points to make sure that everyone else across the board understands we're not playing here. You know, like this, there's no opportunity for us to try and game the system. We had, you know, I can recall a scenario where there was a pregnant patient who came to us and said, I would like to terminate. They said, well, we won't pay for it unless there's a medical indication. Okay. I don't know exactly what a medical indication is that justifies termination. Like that should be a decision between a pregnant person and their healthcare provider. But what ended up happening was by the time the family had collected enough money to pay for this, the patient had advanced into her second trimester, which means that there was more that instead of being a DNC, it was a DNE, and the cost of that was higher. And so we're creating these barriers, and even when we think that we're able to overcome them, we're bringing up these new barriers. And those are exactly the things that we need to not allow to happen. We need to create accountability in correctional settings to make sure things like that are not happening.
Yeah, absolutely. And I wanted to also bring up, you know, some of these considerations, you know, about communication and infrastructure and financing and getting kind of like, you know, ability to kind of get money to the patient to make these decisions and pay the copay brings up a lot of structural issues that kind of call into question how standards of care really operate very differently in the community than they can even physically operate inside of spaces of confinement. And I just wanted to bring up, and I know Dr. Himmelstein, we were talking about this article kind of earlier today, and I just wanted to highlight, and Will, I wanted to get some of your reactions about like when you've spoken to different patients and clients through the Medical Justice Alliance work, thinking about what's happening in this article, Bruce Western kind of terms inside the box, in terms of a very physical difference in the space that patients are receiving care in, the architecture of prisons, competing priorities between security and health, which we kind of alluded to earlier, that the physical space is really not prioritizing kind of healthcare and wellness and, you know, the ability to kind of freely decide how and when to get exercise, how and when, which diet you would like to follow. And I just wanted to get your take on kind of how this has manifested in when you've spoken to kind of patients through the clients at Medical Justice Alliance. Have they spoken about kind of these elements as well?
Yeah, that's a good question. And just even thinking about like the whole milieu of health around like the prison environment, I think we definitely see a lot of patients where, you know, they are struggling with, you know, diabetes or something like that, and we say, well, it's good to get exercise, and they say, you know, I'm in protective custody right now, so I'm in segregated housing where I only get 30 minutes out of my cell a day. And we're like, you know, typically we do tell patients eat low carb meals, or, you know, there are other ways to help control medically from like a lifestyle factor that could help with your diabetes. And they say, you know, this is the food I get every day. And the commissary food is all just packaged goods that are generally high sugar, high fat, high carb. So I think there are a lot of different ways where even if they understand how to best take care of themselves, they're not set up for success. They don't have very good access to fresh fruits and vegetables. They might not have good access to exercise equipment or outside time. So there are many, many different ways where, you know, it really just, it hampers their own care.
Absolutely. Yeah. And I think that there's, you know, a couple additional layers too that, you know, apply to a lot of patients across the country in terms of, and, you know, just kind of for visual representation, I'll kind of talk through a little bit of this. And then David, I'd love to hear kind of your take on some of these visuals of, you know, solitary confinement being an element that, of course, as, you know, very difficult to really standardize care when there's other elements that have to do with like security or safety that are imposed on a patient without any kind of awareness or, discussion with their medical team about what the impacts of that confinement might do to a person. But of course, as we see here, and it's, on the left side of the screen is men and right side of the screen is women. And on kind of the y-axis here, we're looking at serious mental illness and the average kind of number of days spent in confinement of those with serious mental illness, kind of moving down to having a current psychiatric diagnosis versus a prior diagnosis or no mental illness. And of course, it is quite striking that we can see, some differences between men and women, but across the board, serious mental illness between men and women are going to have a higher, density plot kind of centered around a larger number of days than people with no mental illness or those with a prior psychiatric diagnosis. So our patients that are most vulnerable are those with serious mental illness, and really trying to, how do we work to really get at some standards of community clinical mental health care when we have these other very large structural and system issues that are kind of pushing back against the implementation of standards of care. And David, I just wanted to kind of get your reactions to this this finding.
Yeah. Well, a couple things. One, of course, is that what this indicates is that torture is routine in America today. 5% of folks in prisons are, roughly 5% are in solitary at any one time, and 40% experience solitary during their incarceration. And almost all of that is under conditions and for length of confinement that the UN would define as torture. So we're routinely torturing people, hundreds of thousands of people in our prisons. And if you don't have mental illness, when you go into solitary, the vast majority of people who are in solitary for 55 days, for instance, in the course of their incarceration, will develop mental illness, often very severe mental illness. And generally, our prisons are the largest mental institutions in major cities around the country. So we've chosen not to adequately deal with mental illness in the community. And we have this horrendous method of dealing with mental illness, which is to say when people misbehave according to the guards, and what that means is, depends on the guard's definition. We say throw them in the hole and it's going to make things much worse. So this is sort of one horrendous example of what we're doing. We need to get people out of prison. That's the most important improvement we could make in prison healthcare, is to cut the number of people imprisoned radically, at least 80%, maybe it's 95%. My children would say 100% they're prison abolitionists. And we need to stop this kind of segregation in all but the rarest of instances. So, and we need to have adequate treatment of mental health for people in prisons, the few who maybe under some circumstances one would say should be there.
Yeah. And Eric, I know you were in New York City when, I'm going to just kind of put this image up on the screen, when the pandemic was happening. And of course, you mentioned your work at Rikers Island. There was a lot of, national awareness, rightly so, to try to bring attention to, as we mentioned, the infectious diseases being one of the standards of care that, does have some kind of statutory and, precedent in our legislative bodies to really kind of think about how do we intervene with infectious disease outbreaks. And this, of course, was like a moving average of May through September in 2020 of cases per 100,000. And I do really appreciate that what this graph maps, and you'll see, is incarcerated persons. And again, we're going to be using terminology, incarcerated, justice involved, kind of a couple different terms. Prison staff is also listed on here, and then general population at the bottom line. And I thought this was really striking. And I was going to ask, kind of about your experience about managing this, kind of crisis and true threat to the standard of infectious disease prevention and care in New York at the time, but also really interestingly about, is there an important way in your work that you've really aligned with those who work at our facilities, the prison staff listed here, who also clearly were at, a very increased exposure to COVID-19, and kind of how have you seen that, play out in your work? And was that a source of alliance in your efforts to kind of help standardize, infectious disease outbreaks that like COVID-19 in Rikers Island affected not only the justice involved patients, but also the staff and the entire facility?
Yeah, it's a really great question. And I have to say, Kara, I love how you presented this right up next to the discussion about solitary confinement, because I think what we saw in many places was trying to somehow justify, the use of solitary confinement to be able to contain an outbreak. And it's a strategy that didn't work before the pandemic. It didn't work in the pandemic, and it still doesn't work as we've moved past this public health emergency. But the issue of correctional staff during the outbreak was a very real issue, and I think it really just shone a light on the fact that there probably is not a correctional setting in this country that is well prepared to be able to address some of the challenges that you're going to see in a public health emergency. And it goes beyond just the experience that we saw in COVID. We look at the Mpox outbreak in the summer of 2022, which also had a significant impact on New York City and some of the other large urban areas. And obviously, the mode of transition there is very different. It's primarily contact, as opposed to COVID-19 and the special droplet mechanism of contagion that we're talking about there. But even it's something that requires contact isolation. The likelihood of greater transmission in a correctional setting is a very real thing that we have to overcome. The staffing piece actually was something that was quite challenging. In fact, I know that then Mayor de Blasio in New York City had taken on a lot of efforts to try and do whatever was possible to get many of the jail and prison staff back to work as quickly as possible. And it's because you can't, we have so many people who ended up in a de facto solitary confinement situation because we just didn't have the staff to be able to manage the logistics. And also, I think that we sort of forget that that jail and prison staff, they're frontline workers, right? I mean, and so when we're talking about a pandemic, we have to be able to be mindful of how we can try and build in an extra layer of protection for that group of people, because we really rely on this group of staff to be able to meet the needs of our justice involved patients, particularly when they're in a jail or prison setting.
Yeah, thank you. And I can only imagine kind of navigating all of those layers in real time, really trying to kind of make decisions and build alignment. And I think that in this work, coalition is essential. And priorities are different. Oftentimes we kind of brought up security and safety can mean different things, of course, from healthcare workers like ourselves, versus, kind of the very real needs of, U.S. jails, prisons, and detention centers. But kind of finding those distinguishing points for alignment and where to push back is essential. And before we kind of transition into the Q&A with the audience, Will, I just wanted to get your take on one other graphic, which was very striking to me, in kind of your work with thinking about the whole person, the whole person who is now not able to advocate for themselves in spaces of confinement. This was sort of a very interesting survey across state correctional facilities, and a combination of surveys of prison inmates, Bureau of Justice Statistics, across the years. And enrollment in drug education, job training programs, and work assignments in state facilities regionally, which I think is really interesting. And as we spoke about last week, very hard to, we can only get certain types of data. There's a lot of transparency and privatization and kind of things that are in the way of data. But this is, pretty good regional data, but we're seeing very clear, trend down in how we're able to kind of while in spaces of confinement, enroll in all these different kind of opportunities that may help normalize what, would be routine recommendations for physicians to patients in the community of, some, drug treatment, education, awareness, being, in a space where you're employed and kind of have work assignments or duties and responsibilities and obligations kind of to keep you on a schedule. I just love your reflections on kind of what we're seeing across the board with decreased enrollment across the board and how that makes the job of medical providers and healthcare kind of prescriptions of priorities very challenging, and maybe what you've seen in your work.
Yeah, I think you can all see how these numbers have been decreasing. I think there are kind of two major things that at least I've seen in my personal work. So one, I think whether it's the medical side of things or whether it's more on the correction officers, I think staffing has been a big issue for prison facilities in many places, even like here in Illinois, it's 30 to 40% of nursing jobs, or upwards at some facilities, upwards of 50% of medical staff positions are unfilled. And so when you think kind of across the whole facility, then if they're unfilled positions, they can't be providing work options, education options, or this other programming, which is demonstrated to have better effect in helping people get rehabilitated, helping them do much better once they're released. I think the other thing that we've talked a little bit about is just like the effects of prison on the health. And I think so when we're looking at your life expectancy, so studies in New York have shown life expectancy drops by about 2 years for every year you're incarcerated, partly in response to the difficulty of getting medical care. So these are patients, what I've seen patients who, 5 years ago were healthy, and now because of uncontrolled chronic illness or other things where they didn't get treatment, they've lost legs, or they are unable to work now because they have disabilities, in part due to the medical conditions they've had. So I think this is a very multifactorial problem, but I think when you keep patients healthy, when you keep people healthy, they're much better able to work, to get education, and that will ultimately help them thrive a lot more once they're released.
It's also
Absolutely.
worth mentioning that part of the trends we're seeing here reflect the huge increase in the number of people incarcerated during the period between 85, when those graphs began, and about 2008, when the prison population kind of peaked. And as you've had huge numbers of people incarcerated, if you don't ramp up the number of people, of folks able to deliver drug programs, education, job training, and so on, the share who will actually be able to get those programs necessarily goes down.
Yeah. And another thing is the aging population of people who are incarcerated. So, as people are older, if you're plus 65, plus 70, it's going to be hard to start a new job or get a new work in prison. So I think just being aware there are a lot of factors here, and it's an indicator that probably some of these people should be released.
Absolutely. Yeah. Thank you. There's so much nuance here. And I want to transition kind of into our, we have about 20 minutes kind of for a nice rich opportunity to kind of meet some of our audience members. And I'll kind of let Katie kind of take over some of the Q&A. I just think that we're at the tip of the iceberg of figuring out kind of what lies beneath this huge, immense system. And, when somebody asks me, should there be standards of care across US jails, prisons, and detention centers, as a physician, of course, who operates, with clinical guidelines and, all the evidence base that we have, I feel like there's a gut reaction to say yes. But I think as we've kind of started to tease out here, there's so much more nuance in this space regarding like who's implementing those standards, how are they being enforced, who's updating them, what are we holding that standard accountable to, and all of these rich discussions about like the actual architecture of the space and how that precludes a lot of the things that we would prescribe as standard of care, has really complicated the answer to that question, and I'm kind of gleaming that. that it's not such an easy question to answer to just say yes, because if yes, then how, who, why, what, of course, quickly follows. But I would love to hear from our audience, and kind of as the wheels are turning, I'll turn it over to Katie to hear a little bit about what you guys are thinking about. And thank you to our speakers.
Terrific. Thank you all so much. We have a few questions in the queue, but if people have other questions, feel free to just drop them either to me as a direct message or in general, or just raise your hand. The first question came from Jennifer Piper. Jennifer, would you like to unmute and ask your question?
Hello, this has been super informative. I don't actually have it in front of me, what I put in the chat.
Okay, I can read it for you. It's no problem.
Thank
Just
you.
want to make sure you can engage if you want to. The question was, are there efforts to join forces between lawyers, people detained, and physicians? I don't know if you want to expand on that at all, Jennifer.
No, if it makes sense, I'd love to hear what the panelists have to say.
Terrific. Maybe we can start with Will and then jump in, because I think that's part of what Medical Justice Alliance is doing in part.
Yeah, so fortunately, I think there are a lot of physicians who have identified this as a big problem that they want to support. So the Medical Justice is a medical legal partnership. So especially any of you on here who are physicians who would be interested in volunteering, it's an easy way to get involved. Usually a case, it's 4 to 6 hours over the course of 4 to 6 weeks. 4 to 6 hours total, where you're just reviewing medical records, and then just with any of your patients, you're explaining what's going on in the medical side, and we provide mentored support. So I think Medical Justice Alliance is one example of this medical legal partnership where patients who are behind bars can work alongside their attorneys in raising their concerns, and we really partnered the physician with them to provide these free expert witness services. And we found significantly improved rates of both getting appropriate medical care and then compassionate release. So we've talked briefly about patients who are either permanently disabled or terminally ill can qualify for release under the law. And we found that nationally, it's less than 15% of people who are released when they apply. But when you pair them with a physician who can explain it to the judge or the parole board, and internally at Medical Justice Alliance, it's over 85% of patients can do it. And again, that gap is a gap of understanding with the parole boards, with judges. So I think once you can partner the people who are behind bars, their attorneys, and a physician, you really do see results.
I'd just like to editorialize for a second and offer that sometimes these can happen also in kind of unconventional settings. I know there are groups that have worked to pass primary caretakers laws all around the country, in Massachusetts, in Kentucky, and in other places, to try to allow for judges prior to sentencing to consider the role of incarceration as an adverse childhood experience on dependent children of incarcerated parents. And so thinking creatively about how physicians, child psychiatrists could partner in developing those kinds of affidavits to support that as an effect, not only again on the incarcerated patient, but also on their families more broadly. Just wanted to offer that as another strategy where folks could get involved. I'm going to move to the next question. Sharon, you had the next question. Would you like to unmute and ask your question?
Katie, I'm the same way.
I think we lost you for a second.
Oh, okay.
There you are.
Okay. Thank you. I think I am also like Jennifer. I was so engrossed in what was being said. So if you wouldn't mind, because
I wouldn't mind. Your question
Thank you.
was, where does staffing come from for the prisons? Who are the staff members and who monitors their work?
And then
Anyone
I'll
on the
go
panel?
on after that.
Anyone on the panel want to jump in with for those of you who have worked directly in carceral facilities, want to kind of tackle that question?
I think the answer is it depends, and it depends on what role we're talking about. I can say that just from the medical staffing standpoints, I felt very fortunate to work in two settings where this work has been really prioritized. You know, I think earlier but earlier in the conversation, it was brought up that, you know, the quality of medical care and the quality of the people providing that care is certainly, you know, has come into question in some settings. But I still think that there is a not insignificant amount of highly motivated, socially driven people who really want to come into work in a setting like this because they want to experience it, they want to work with the patient population, and they want to make things better. And I think that the more that we can try and build up those kinds of pathways, you know, like I'm a huge proponent of incorporating, you know, some degree of correctional medicine into training in various specialties, including family medicine, internal medicine, emergency medicine, because regardless of where you're practicing in emergency medicine, like this is going to happen, like whether it's somebody who's in custody, somebody coming from a correctional setting. And so the more that we can make sure that we are incorporating this into the training of different programs, so that we're creating the workforce that really are most adept and well prepared to work in these settings. Like, I just think that that's going to go a long way. Although I will say, like, the best thing that we can do to improve the health of justice involved individuals is criminal justice reform, right? Get them out of jails and prisons in the first place, at least to the extent that we can. I know that that's more political than healthcare focused, but the reality is the structural barriers are so great, and so I think we can't lose sight of that element of this. That when we account for 5% of the world's population and 25% of the incarcerated population, it is a reminder that there are other ways that we can be doing this, and we really should focus on how we might be able to do this differently.
Okay, well, thank you. I'm in a state, we have been working on criminal justice reform for some time. We do have communication with some of those who are incarcerated at this time. One gentleman, he is much older. I appreciate the comment about compassionate care, because it does appear in this state that compassionate care is not something that they want to, you know, try and do. But he needed oxygen, and his oxygen was gone, and they told him to sit down and be still. And so, you know, it's those types of things. And so as an organization that is working on criminal justice reform, what are some steps that we can take in this area? Because the group that I'm with, we call it cages. Okay. Because we feel that people should not be in a cage. And so we always talk about it in that manner. So what could we do to try and push, press? I mean, you know, we're open because, you know, some of us on our team, we won't say it out loud, are also abolitionists. You know, we don't want to scare people, but we are. And so if you could share some information about how we could go about this. Like, I like the compassionate care thing, because with the physician, because that sounds excellent. I don't think that that's anything that's ever been talked about before. So that's a good nugget for us. But if you have anything else, I'm open.
Thanks for that question. Any of you want to tackle the kind of what you would think of as being the sort of top high yield policy interventions of people who are pushing for legislative or judicial or policy change within the prison systems? What would be the kind of goals that you all would focus on?
David, I know you've written a lot about this.
Well, you need to get people out of prison. I mean, any measure that gets people out of prisons and jails, you know, what the bail system needs to be changed. We made some progress on that in New York State for a while before a backlash kind of reversed at least part of that process. But why do we have so many people in pretrial detention when they're presumed innocent? Huge numbers of people. And then sentencing changes are also enormously important. Someone just put in the chat, ban solitary confinement, certainly an important measure. Just to your earlier question, I would add that one of the things I think we need to do is to say that we shouldn't isolate um, carceral medicine from other medicine. So I don't think doctors ought to just be doctors for people in prison. That they ought to be practicing in the community and in prisons and jails, because that actually makes for a very different attitude. I see somehow in the chat Norma Wassels, not in the chat but on my screen, Norma Wassels' name, an old friend who was instrumental in some of the legal actions in California 40 years ago about improving prison healthcare. And one of the things back then, my partner, who was a community physician and also a physician who cared for people in the high security prisons in California, made a huge difference in the standards of care that were actually there for people in incarceration.
Thank you so much.
Thank
The
you for
one thing
that.
that I'll add to that is one of the things that we were doing when I was working at Rikers Island was buprenorphine induction, right? And to me, like it really was a highlight on how important it is to think about transition planning, particularly when you have not just opioid use disorder, right, but any high risk condition that is going to leave you in a vulnerable state as you're transitioning out, particularly if you're in a state where you're not allowed to have your Medicaid be activated immediately around the time of release. So trying to be more thoughtful about how we do transition planning when we're talking about chronic disease management, I think that that's something that really can go a long way as well.
Thank you.
Yeah, the
Thank you, Katie.
No problem. Go ahead,
Medicaid
Randall.
has been an issue, and as much as states can continue moving and getting rid of that waiting period, or even getting people enrolled early, because I've had patients who've been released from prison, and I've had to write prescriptions for them and like evaluate them because they weren't provided their insulin at release, and it's going to be weeks until they can get onto Medicaid or Medicare, and so I think there are big gaps in care. And if we can get them transitioned effectively, that will help everyone. It's going to help everyone in the community, and it's going to mean that they don't have to go to the ER for care and create longer wait times for the rest of people for things that really shouldn't be emergencies.
Terrific. We have 3 more questions in the queue so far. Next up is Tess. Tess, would you like to unmute and ask your question?
Yeah, thank you so much, everyone, for this panel discussion today. It's been so inspiring. I'm eager to bring children and youth in custodial settings into the discussion. I know we all know children in the youth and youth justice system, particularly those in detention, have complex health and mental health needs that are exacerbated by detention. And so even though there's been a decline in youth detention numbers since around 2020, there's still an unacceptably high number of youth, particularly youth of colour, confined in detention settings. So I've been working with Josh Stenkoff, who I think is on this call, and Dr. Elizabeth Barnett, who might be on the call too, on a landscape mapping, looking at the standards for medical care in detention across the US. And we've seen that to fill the kind of national gap that we've talked about today of sort of national level standards. A lot of states have stepped in and developed their own state-based standards, whether it's in legislation or administrative code or policies. And what we find is that the bar is low in most states. Most people would be surprised to learn, with sort of very few states reiterating community standards of care. So touching on this, I'm wondering if our panelists would have any reflections they could share around strengthening standards in care, particularly for youth in detention settings or settings where children are deprived of their liberty. Thank you.
Eric, do you want to start us off?
So here's the caveat, right? Kids children are an area where I just don't have as much experience, so I'm not sure that I can speak in as an informed way as others on the panel. I will say, I'll just reiterate what I said before, right? Which is the best way to improve healthcare is to get them out of correctional settings. Like we think about, I mean, so in Rikers Island, they do have, one of the jails on the islands is geared towards 16 and 17-year-olds. And what was interesting is they also, that was the same facility that at the time they were using for geriatric patients. And I understand where that thought came from, but honestly, like trying to have those two groups of people within the same facility was incredibly problematic, right? So just to reiterate, like I think it's really about trying to make sure that in every possible instance, we are getting kids and young adults out of correctional settings. That's going to be the number one way to do this, is really addressing that piece of correctional justice reform.
I mean, we have a system where basically the white kids from wealthy or upper middle class families virtually never end up incarcerated. If they misbehave, you call the psychiatrist, and if poor Black kids misbehave, they call the police. So the change, the first change we need is a change to that impulse of who do you call when a kid's in trouble? Do you call the police or do you call someone to help them? One of my children worked as a math teacher at a high needs public school in Brooklyn. And when someone misbehaved at the school, the one of the calls was to the police department. So, so inappropriate for that to be the impulse. So I think we need to go back, well before incarceration in most cases, and say, I think prison abolitionism is clearly the right thing to do. We need very different institutions to help kids than what we have today.
Thanks,
I
folks.
really appreciate that you're doing all this work, especially with youth. I think we see it less in the Medical Justice Alliance, especially because many times their medical needs aren't met, although mental health needs are so high in this population. And I think we also see that their educational needs are many times not being met. So there are organizations or states, even like in Massachusetts, they have put forward legislation to try to get a community standard of care, not just for youth, but across the whole spectrum. And I think no matter what, it's going to help to have a community standard of care, whether it's youth or adults.
And just to put some numbers to this, years ago, Lindana Morass from our group at Cambridge Health Alliance and Harvard published a study showing abominably low treatment rates for mental illness for minority youth, both for substance use and for mental illness problems. So, we don't treat it that way. We just put kids in jail or prison.
Thank you all for that. I'm going to put in one more plug for it, dropped a link in the chat to a series we did last fall on abolition. If anyone is interested in going back to revisit those videos, that was our topic last fall semester. So if people want to go back and catch up, by all means, we encourage that. We have time probably for one more question. Eliza, you had a question. Would you like to unmute and ask your question?
Hi, yeah, thank you so much, everyone. This has been really instructive. My question was just following up on something that I saw happening in the chat that seemed really interesting. People were talking about these, I guess they're called Medicaid 1115 waivers, and how that could basically end for-profit companies such as WellPath. So I was wondering if I could get sort of just an overview of what that might look like. I know about WellPath and those for-profit companies, but sort of how those waivers might really be powerful in that regard. I'd love to hear more.
Yeah, and I just want to add a plug for the fact that on November 20th, this is going to be one of the main topics of our event that day. So if folks are interested in this, we encourage you to come back and have a deeper dive. But certainly the experts on this panel can speak to this as well. So I will open the floor.
I guess the one thing I'll say to start out with is, so I live in New York. We are a state where hospitals are not allowed to exist as a for-profit entity, and yet, we continue to see that when we're talking about correctional care, that we don't live up to that same standard, and we just have to get away from that, right? Like this really gets back to what I said. Like the standards of care exist; they do not change because somebody is a justice-involved individual. They do not change based on the setting where you are. And the more that we can get back to that, like that is, it really needs to be the standard. I think that 1115 waivers show great promise. We just passed a new one, or CMS, the Center for Medicare and Medicaid Services, just approved our 1115 waiver just a few months ago here, and isn't sort of, you know, directly geared towards justice involved individuals, but is really geared towards, you know, health related social networks and, you know, addressing all of the social determinants of health. Obviously, justice involved individuals fall under that umbrella, and oftentimes it's more than one determinant that usually we end up seeing within this population. So I think that 1115 waivers definitely provide a great potential solution here. That continues to be a big issue is, you know, at the very least, continuity of insurance, both as you're first coming into an incarcerated setting and as you're coming out of that, and making sure that people have access to critical medications like insulin for patients with diabetes, antiretroviral therapy for patients living with HIV and AIDS, hepatitis C medications, you know, just all of that. I think that there's great promise with 1115 waivers and being able to help us solve some of those complicated problems.
And my understanding is that, I mean, an 1115 waiver basically says a state can use Medicaid money for things that normally Medicaid wouldn't be allowed to cover. So my understanding is that most of the 1115 waivers for correctional settings have been that during the last 90 days of someone's incarceration, they can get Medicaid. And that really helps the transition. It doesn't change too much else, I think. If you had Medicaid coverage for the entire incarcerated population, for instance, then Medicaid standards of care, for instance, and regulations would apply to the care of that population. But it's only folks immediately before their release, or in the short time before their release at this point, who are going to be covered by the waivers, as I understand it. Might also, if you had full Medicaid or Medicare coverage or single payer coverage, help to mainstream the care of the incarcerated population and not have it isolated from the care of the rest of the community.
Absolutely. And I
Thank
think
you for
that's
that.
been, yeah, kind of a beautiful way to kind of wrap up the conversation on, to your point, Eric, about, you know, what does standards of care mean really across the board, and to think about this whole population. We're going to have to solve this, you know, challenge together as an entire population, and thinking about standards that would be applicable to all, with considerations of the very unique and challenging spaces of confinement. But really thinking about raising the bar consistently, and never lowering the bar, and never making excuses or kind of, you know, alternatives as the default. I really appreciated, we didn't get to hear from everyone in the chat. I'm so sorry, but I appreciated, just to wrap up, John Fabricius's comment. And thank you for sharing a little bit about yourself and your background, and kind of using this term of like government accountability instead of like the criminal, like feeling like things like kind of rest on the criminal justice system, but thinking about that word accountability, and kind of how we as individuals and as coalitions can kind of raise, you know, a call for accountability as a group. So I'll be thinking about that a lot, as well as a lot of the themes. And I just wanted to thank our speakers so much for being with us today. And yes, definitely a plug for the rest of the series, which will tackle things like transparency, accountability, data, and then particularly the 1115 waivers. We have a couple experts that are actively pushing out 1115 proposals as we speak. So they'll be joining us later in the series. But thank you to Dr. Himmelstein, Dr. Eiding, Dr. Weber, really, truly wonderful experts. And it was a pleasure to be with you all today. Thank you.
Thank you.
Thank you all so much.